Hey everybody, we're going to get started in just a moment here. Just waiting on Dr. Mariano to join back with us. There he is. All right, well, we're going to get started. We've got some of our poster presenters on deck waiting to get started. So before we get started, I want to welcome everybody to ASRA Spring 21. I think we get to sort of do the soft kickoff of the meeting with this pre-meeting abstract moderated poster sessions. And we had one yesterday. It actually was a great success. I looked, we had about 1,000 views on all the different channels in 24 hours. So even though some people watched live, there's a lot of people that watched after the fact. So it's really exciting to see that this science is getting seen by probably more people than would even see it if they presented at the meeting itself. So this is a great venue for doing this. I want to remind people that ASRA Spring starts on Thursday. And for those of you guys that are there at the meeting, which we'd love to see you at the meeting and come say hi to us if you're there. Or if you're not at the meeting and you're following from afar, make sure you follow the hashtag ASRAspring21 and you can see a lot of the conversation going on social media. And hopefully, if you haven't decided already and you want to, you can join the virtual meeting. So for those people who can't travel for whatever reason, you can still sign up for the virtual meeting. There's a lot of the presentations from the podium are going to be presented on the virtual meeting, plus some pre-recorded stuff and some live workshop content. So there's a lot of good material in the virtual meeting as well. So that's another way to experience the meeting, even if you can't travel this year. And then that always keeps you revved up and excited for coming to the next one. Well, today we have 8 poster presenters. We have 8 young scientists presenting their work. We're really excited to have them present this stuff because this is where all the new ideas come from. And oftentimes the literature that's 1, 2, or 3 years down the road, you see the hints of that in some of this early work. So we're excited to see it, to talk about it, and hopefully find some of our new rising stars in this group of people as well. So hopefully you'll see faces that you'll meet many, many times in the future. So without further ado, and Jan, I'm going to throw you up here as well. Hey, so we've got people joining us. Hey, Ed Mariano, so coming to us from California, and Jan Bublik's also coming to us from California. Let me take this little banner off because we're already starting. How are you, Jan?
I'm good. How are you guys?
Doing
Great.
Well.
All right.
So we're going to get started with our first presenter, and then we're going to have Dr. Aman Nada, who's going to join us as faculty here in a few minutes. She's running a couple minutes late, but we'll have her join as soon as we can. So let me get our first speaker up here.
Hello, everyone.
Hi.
Welcome.
Apologies for not saying your name correctly, but Dr. Haoyan Zhong is going to be presenting her poster. Let me get this up on the screen so that you guys can see. Maybe, let's see. There we go.
Perfect.
So you are presenting hip fracture characteristics and outcomes during COVID-19, a large retrospective national database review. And what we're going to do as far as timing, and this is for all our speakers on deck as well, I want you to kind of try to keep it tight to about 5 to 6 minutes in your presentation. That leaves us about 5 to 6 minutes for conversation as well. And for those of you guys watching online, feel free to throw comments into the comment stream because we'll often engage with those comments as well. So Haoyan, go ahead. Start with your poster.
Hi, everyone. My name is Haoyan Zhong. Thank you for joining me today. I'm from Hospital for Special Surgery, Department of Anesthesiology, Critical Care, and Pain Management. And I'm a biostatistician there. So the COVID-19 pandemic has impacted healthcare in various vulnerable patient subpopulations. However, data is lacking on COVID-19's impact on hip fractures, seen mainly in elderly patients. So we use the national claim database. We aim to describe the epidemiology during the first US COVID wave. This study was approved by our institutional review board, and patient information were derived from premier healthcare database. So we selected patients who were diagnosed with hip fracture upon hospital admission during March and April of 2019 and 2020. We selected patients of COVID wave from March 1st to April 30th in 2020 because these were the most recent data available to us at the time of analysis. And in order to compare this cohort to controls, we selected patients admitted during the same time frame the year prior. So this was because fracture incidence and volumes have seasonal variabilities. So our variables of interest include patient and healthcare characteristics, COVID-19 diagnosis, and outcomes. And we were also able to capture fracture types and types of surgical procedures, or if the patient received non-surgical treatment after hip fracture. Descriptive analysis was stratified by year as well as by COVID-19 diagnosis within 2020 cohort. Given the descriptive nature of this paper, all p-values should be interpreted carefully. So for our major findings, we found more than 50% reduction in hip fracture volumes were observed in 2020 compared to 2019, the same time period. And absolute differences of patient and health characteristics between the 2 years were actually relatively small. And regarding outcomes, patients with a hip fracture during the COVID-19 surge were actually discharged 1 day earlier compared to the cohort admitted in 2019. And what's more, patients were less likely to be admitted to an ICU post-operatively and more likely to be discharged directly home during COVID-19. There were no differences between the two cohorts in readmission rates, use of mechanical ventilation, overall ICU days, or complication rates. And then we identified 83, which is 1.1% of patients of the 2020 cohort who has a hip fracture and also a concomitant COVID-19 positive diagnosis. And compared to non-COVID-19 patients, these patients were more likely to be non-white, to have higher comorbidity burdens, to be on emergent urgent trauma admissions, to have Medicare Medicaid insurance, and then to receive non-surgical treatments. And COVID-19 positive patients were more commonly admitted to urban and teaching hospitals. The majority of these patients were admitted to hospitals located in Northeast, which was consistent with the geospatial surge of the first COVID-19 wave in the US. And then COVID-19 positive patients stayed in the hospital almost twice as long as non-COVID-19 patients, with a median length of stay of 7 days compared to 4 days. And the in-hospital mortality rate was 14 times higher compared to non-COVID-19 patients. And they also suffer from higher complication rates. For discussion, we identified a significant reduction in the admission volume of hip fracture patients during COVID-19. So this finding may possibly in part be attributed to the lack of activity during the periods of the stay-at-home orders across the country. But interestingly, the outcomes associated with hip fractures care were not compromised, despite all the challenges hospitals were facing during the COVID-19 surge. We found that in-hospital mortality rate, readmission rates, use of mechanical ventilation, and complication rates were not actually different during COVID and pre-COVID. And patients were actually discharged 1 day earlier and had a lower chance of being admitted to ICU during COVID-19. This may be because there was an increased focus on expedite care and then remove patients from potential at-risk environment such as hospitals. But in addition, this finding may also suggest that previous approaches to patient care in this cohort may be too conservative in the timing of discharge from the hospital. But we agree that future studies are needed to provide further insights into alternative approaches to discharge decisions for hip fracture patients. So COVID-19 positive patients definitely experienced significantly increased length of stay, higher risk of post-operative complications and mortality, which has been shown in a lot of other publications as well. There was no change in non-surgical approach and type of surgical repair observed in 2019 and 2020. However, we do find that COVID-19 positive patients were more likely to be treated in a non-surgical way. So this finding may have numerous reasons, including lack of necessary resources, the avoidance of airway instrumentation, as well as a risk-benefit analysis in an already at high-risk population. Our study has limitations. First, the geographic level identifier in Premier is limited to region level. So we were not able to identify the hotspots during COVID-19 and control for its effect on patient outcome. And then secondly, the relative difficulty of obtaining COVID-19 testing in March and April 2020 may have resulted in some COVID positive cases actually being unrecognized. And also because of this relatively small number of positive patients, it is difficult to know how generalizable our data can be. And then lastly, the existing database does not contain long-term follow-up of the COVID-19 cohort yet. So there may be long-term differences that were not yet captured by our study. Yeah, that's the end of my presentation. I'm happy to take any questions you guys have.
Thank you so much. That was a great presentation. A lot of interesting questions come out of that work, I think, as much as answers. And just as a note before we get to the conversation, for those poster presenters that have joined the conversation, I do see you on deck, and I will add you to the conversation when we're presenting your posters. So just enjoy the previous conversations while we're waiting on the presentation from you. So I'll start off with a quick question. You mentioned that non-surgical therapy was one of the things that increased during the COVID pandemic. Was there any data that you could extract that regional anesthesia as a choice or avoidance of general anesthesia was increased during the COVID cohort of patients?
So for non-surgical approaches, they are actually the same pre-COVID and during COVID. The only difference we find is just for COVID positive patients, like they were more likely to receive non-surgical treatment. And we didn't look into like general anesthesia and regional anesthesia. They were the same, like between like pre-COVID and during COVID. But the limitation here is because we're using a claim database, so we can only identify their anesthesia like a procedures through CPT or billing code. So like around 30% of them are like unknown cases. So because this number is just too large, we didn't include this variable in this analysis.
Any other faculty? Ed, go ahead.
Yeah, I thought this was really interesting. I mean, I think that we all know that this has been a really interesting natural experiment for healthcare. And I think the question, at least the way they interpret your background, is that that it's difficult, except in situations like this, to really see how health systems adapt to changes in practice and resource utilization, and does the care paradigm shift in such a way that care of the patients changes. I thought it was interesting that that there would be a decline in number of cases, since we don't tend to think about hip fracture care as being completely elective. That was just one observation. What the question I had was, when you look at the snapshot of cohorts, because it's a nationwide claims database, and there were the timing of surges for COVID differed in different parts of the country at different times. Did you look at trying to see whether there was some way to match, I guess, what I would perceive as maybe the healthcare burden of those particular regions and the outcomes for the patients who had hip fracture care?
Yeah, that's one of the major limitations we have here, because like in Premier, we can only identify patients by their region, like Northeast, Midwest, South. So that's like a general level. So this is a very interesting question. I think maybe it's worthwhile to just look at Northeast population by itself, because 70% of the COVID positive patients in our finding are actually from Northeast. So maybe it's worthwhile to break it down. Yeah.
Yeah, it's interesting. Thank you.
Thank you.
We have I think we've got a lot of posters today, so we're going to move on to the next poster. And but we really appreciate your presentation. Fantastic work, and we look forward to seeing more of you at future ASRA meetings and more of your work. So thank you again for presenting.
Thank you, everyone.
All right. Our next presenter is going to be Dr. Yvonne Nguyen. Is it Nguyen?
Yes, Nguyen.
Did I say Nguyen? Okay. And I am going to bring your poster up here. And I think that's yours. Yeah. So it's entitled Regional Anesthesia in Management of Upper Extremity Burn Injuries. And take it away.
Alrighty. So hello, my name is Yvonne Nguyen. I'm one of the residents in anesthesia at VCU. I collaborated with the VCU Evans-Haynes Burn Center for this project, where we are fortunate enough to be the region's resource for care for a lot of acute burns. Our study aimed to evaluate the impact of upper extremity peripheral nerve blocks in the management of patients with acute upper extremity burns requiring operative intervention. We hypothesized that the use of upper extremity blocks would be associated with reduced hospital length of stay, post-operative pain scores, and opioid requirements in this patient population, given that most studies have these findings when we add on regional anesthesia. So as an overview, burn injuries have continued to persist as a major cause of acute injuries in the United States, with several different mechanisms, and continue to have significant death rates, as seen in the pie chart on the left side of the poster, describing associated fire locations, and in the line graph to the right of it, demonstrating home fire death rates. Burn injuries have been common throughout the years, but we have not yet really optimized care for these patients. Burn patients are well known for developing quick and significant tolerance to opioids due to the nature of their injuries, but other modalities for pain management have not yet been thoroughly investigated. Regional anesthesia has definitely emerged as an important adjunct for pain management in patients undergoing upper extremity surgery, and are increasingly being used as a means of pain management in burn surgery. But information was very limited on the efficacy of peripheral nerve blocks, specifically for upper extremity burn injuries in the acute setting. So to better understand the efficacy of regional anesthesia in acute upper extremity burn injuries, we developed a retrospective study with the excellent help of our IT colleagues. We were able to obtain our goal sample sizes based on our pre-study power analysis. So we ultimately had a total of 266 patients randomly selected from the total pool of patients treated at VCU requiring operative treatment and meeting our selection criteria. The control cohort consisted of 191 patients who underwent operative management of burn injuries without any regional anesthesia. And our regional cohort consisted of 75 patients, each of which received some form of upper extremity block as seen in Table 2. Regional anesthesia approaches included supraclavicular, infraclavicular, interscalene, and axillary blocks, which were single shot injections with or without a catheter placement, and were all done under ultrasound guidance. The selection of the block was determined preoperatively based on the location of the burn and where often the patient felt like they had the most pain. In Figure 3 in the middle of our poster, you can see an image of a supraclavicular block done on one of our burn patients. So when the data was collected and analyzed, we found a 20% reduction in hospital length of stay with means of 10 versus 13 days respectively, as seen in graph 1. And similarly, a 23% reduction in overall opioid requirements in the regional group, as seen in graph 2 on the right side of the poster there. So with these findings, reduction in both length of stay and post-op opioid use, which is usually linked with pretty significant post-operative complications in burn injury cases, these findings suggest that regional anesthesia may offer a significant means to improve patient care in burn cases. and hopefully limit the future complications that are already so multidimensional in burn patients. We are very fortunate to have a large burn center at VCU with significant volumes that have allowed us to develop the study. So we aim to expand our study in the future to investigate other post-operative measures and complications to better understand the role that regional anesthesia may play in the management of upper extremity burns. And we also plan to expand the study to look at lower extremity burns as well in the future. And that's the end of my poster. Oh, I think you're muted, Dr. Gupta.
I have fallen victim to the "you're muted" myself.
It happens to the best of them.
Dr. Nada, you want to start off with some questions for Dr. Nguyen?
Yeah, so Dr. Nguyen, thank you for the nice presentation.
Thank
and
you.
I think, yeah, the strength of this poster is that brings quite a good number of patients from a burn center, which like many of us don't have this kind of procedures or disease they deal with. So that's very informative for the occasional anesthesiologist that comes across those patients. So I have some questions here. So my understanding, those are inpatients, like with major burn injury. And was the burns exclusive to the upper extremity, or they had also some other burns?
So our we had inclusion and exclusion criteria that specifically had only upper extremity burns. So unfortunately, a lot of these patients came in with other traumas related to their event, and those would be excluded from our study. And if they had any major burn injuries elsewhere, such as the chest, abdomen, they would also be excluded from our study.
Good, because that's going to affect the total MME, like you're calculating at the end. Other question also, it's a suggestion if you do a subgroup analysis, but the type of the procedure or the catheter, non-catheter, because the single shot gives like coverage different than the continuous infusion. Right. So that's going to give you more data. The other thing, my understanding that many of those patients are recurrent patients. They come to the OR several times, and some of them need dressings. So, did they receive the regional anesthesia every time they came to the OR? Was that also the regional anesthesia? Did it cover the dressing change?
So, some of the cases that were in this study, they were brought to the OR almost exclusively for dressing changes. And we have a good relationship with our burn surgeons here. We usually try to communicate with them in terms of thinking, is this a patient who's going to require multiple visits? And if so, they're often left with a catheter as long as it stays out of the surgical field. Otherwise, those are the patients that we generally would opt for a single shot.
Nice. Thank you.
Dr. Bublik or Dr. Mariano, any other questions for Dr. Nguyen?
I think Dr. Maria and I sort of like going to have a similar answer. I mean, not just because we're only 3 miles apart, but I think it's just staggering in terms of like the potential it shows yet again for regional anesthesia to impact, healthcare resource utilization, impact on opiate requirements. It's like we don't have to be reminded that we still live in an ongoing opiate epidemic. It's just staggering, like where you see this, like it is like all these confounders that, are obviously there and require SEP analysis, but it's just all these, it's just yet again, it's sort of like similar to rib fractures, right? Not all rib fractures are created equal. So, I mean, this is like very exciting. I mean, I'm looking like, I mean, my head is going many places. It would be interesting to see what the impact long term is. I think it's a great starting point for utilizing what you have at VCU, a really big burn center, which is a wonderful thing. But what you have, you make lemonade. If you have strawberries, you make strawberry cake, shortcake, or something. So, but it ultimately shows just the power and kudos to you. I mean, this is not easy to do. Retrospective analysis seems easy, but anybody who's done it and tries to make sense of it
easy. Yeah.
is is a problem, unless you have a control system like Dr. Mariana, where you can control the change.
I've been very fortunate that everyone at VCU has been very supportive in helping me get all the elements needed.
Yeah.
One thing you may want to do when you, I assume you're going to write this up and submit it. What you may want to do is, one thing that I looked at your baseline characteristics table, and there seems to be a potential difference there in body surface area covered by the burns in your control and regional group. So that may be something that you'll want to account for, especially when looking at some of your outcomes differences. One potential option, since you have such a large database of burn patients, and I don't think that this really needs to be restricted to upper extremities necessarily, but something you might want to think about is matching patients on as many characteristics as you can in more of a matched case control, where you might want to account for some of the body surface area differences.
Okay. I'll need a statistician.
Yeah, there's a lot of work ahead of you, but thank you so much. And again, we look forward to seeing more of this work as you guys evolve it in the future as posters, maybe publications in the journal, and presented at a podium somewhere. So thank you so much for presenting today. And we really appreciate you having this time to talk with us. So thank you, Yvonne. We're going to go on to our next poster. And that is Dr. Justine. Is it Denomme? Justine Denomme? Denomme. Okay. I'm struggling with pronunciations today, so bear with me. Let me get your poster up, and then I'll send if anybody's looking, I'm putting a direct link to the posters on the comment stream. So if you can't see it on this screen, that's an easy way to get to the poster. So this one is entitled Video Conferencing as a Tool for Improving Access to Regional Anesthesia in a Remote Community Hospital. Justine, take it away.
Hi, everyone. My name is Justine, and I'm one of the Regional Anesthesia Fellows at St. Paul's Hospital in Vancouver, up in British Columbia in Canada. And today I'd like to talk to you about a project I've been working on using video conferencing to help anesthetists in rural and remote communities across British Columbia. It allows them to perform regional anesthesia with our mentorship, and it's bringing the benefits to patients in these communities. So to begin, as we all know, the COVID-19 pandemic has led to a dramatic increase in the amount of video conferencing and telemedicine being practiced worldwide. In remote communities in British Columbia, even prior to the pandemic, telemedicine had been used in obstetric anesthesia as well as in trauma resuscitations. For this project, we used the technology to mentor family practice anesthetists in Revelstoke, British Columbia, which is a small community about 350 miles away from our tertiary care center in Vancouver. And just for some context, so family practice anesthetists in Canada would have done 2 years of family medicine residency and then an additional year of specific training in anesthesia. And then at our center at St. Paul's, the anesthesiologist would have had 5 years of anesthesia training. And then as a fellow, I'm doing an additional year of regional anesthesia training. So the project began when the FPA, or Family Practice Anesthetist Group, approached anesthesiologists in our center for guidance in performing adductor canal blocks for knee surgery. They had a new surgeon come to the hospital who previously done his ACL repairs with adductor canal block as part of the anesthetic plan. The FPAs in the past have some experience with the adductor canal block and had some training and experience, but felt that some real-time expert feedback during the block would help to refine their approach. Prior to this, there was a pretty well-established program where the anesthesiologists from our center would go out to these communities and do some mentorship and support, not necessarily just in regional anesthesia. So these relationships had kind of already been established. So in order to tackle this with video conferencing, we started a few days prior to performing the block. Myself and one of the regional anesthesia staff organized a webinar lecture to review the block, how to perform it, had some videos with the FPA group, and then it provided some opportunities for questions and answers prior to actually doing the block. And then the day the block was to be performed, with patient permission, we set up a Zoom call. And then you can see from the figures in the poster, basically we had live real-time audio audio and visual feed of the anesthesiologist performing the block, the patient, and then through a separate HDMI input, we were also able to see the ultrasound screen. So with all that information, we were able to provide advice in terms of ultrasound probe placement, needling technique, identification of appropriate local anesthetic spread within the adductor canal, and even finding the saphenous nerve through dynamic scanning. This session, we used a pretty advanced telemedicine setup, but we've repeated this sort of project in other centers with even simpler equipment like an iPad and a butterfly ultrasound over a Zoom call. So even a low-tech kind of solution has been pretty effective. So this project suggests that mentoring for regional anesthesia doesn't necessarily need to be done in person, but could also be done remotely. This is a big advantage because in most continuing professional development workshops, while there's great opportunities to scan live models and learn how to capture the appropriate view, we don't necessarily have the opportunity to practice needle placement or achieving appropriate local anesthetic spread. In my experience in teaching the residents at UBC and being a resident myself, by the end of our regional rotation and our training, I think we're all pretty confident we could perform a block safely and be prepared to deal with any complications that come up. But I think we're less confident doing blocks on our own and being certain that we have the appropriate local anesthetic spread. So a program like this could really help physicians who don't have a regional anesthesia fellowship trained anesthesiologist on site and who are looking for more feedback or want help in refining their approach. Furthermore, this technology may have other applications. For example, instead of us providing mentorship remotely, we could also have patients with their permission in our block room. We could perform a block with an audience who's viewing remotely. So overall, using video conferencing for remote regional anesthesia can help these anesthesia providers gain confidence in performing blocks and can provide more options for multimodal analgesia in these remote communities. Thank you.
Excellent. Well, let me bring us all back up here. So I'm going to take the first question here. So Justine, this is so interesting for me because I love this stuff. I think this is one of the silver linings of the COVID era is going to be that we're this world that we wanted to live in, but couldn't quite get over the initial hurdles of getting enough people out there comfortable with video conferencing. It is probably going to open up a lot of doors like this. One of the biggest questions I had, and as we've tried to do virtual stuff, is latency. You know, as we've all experienced on Zoom calls, there's often a little bit of a delay. So having a rapid two-way dialogue is stuttered at times, and sometimes we end up talking over each other. When you're trying to guide somebody doing needle placement, did you guys ever feel like that latency affected your ability to kind of slow them down or redirect them in a meaningful way? And what was the anxiety associated with trying to guide somebody from far away?
In the ones I've participated in, again, the FPAs had pretty solid experience in doing the adductor canal blocks, so there wasn't a lot of step-by-step coaching. It was more, yep, that looks good, looking good, like that sort of level. I think in a few of the other cases, there has required a little bit more coaching, but as far as I know, I think there's been no sense of needing to rush or any time pressure. It's usually the first case of the day, so there's usually quite a bit of time prior. So far it hasn't been a problem.
Yeah, I'm also imagining Dr. Probakar's invention of a robot hand that he can just reach in and go, no, move it that way a little bit. You know, I was waiting for that in the screen on your poster, but it didn't happen. But Ed, you had a question for Justine?
No, I mean, I think that it's exciting. I think to see this kind of distance mentoring or telementoring. I mean, I think that in order to improve outcomes for more patients, I think more people have to be able to get access to regional anesthesia. So I think the concept of we've talked about the Plan A blocks or having like a set of core regional anesthesia skills for any anesthetist, so that way more patients have the ability to enjoy the benefits, I think is really critical. And it's not feasible to necessarily send, as you found, an anesthesiologist with specialty skills out to every place, and nor is it reasonable to transport every single patient into a specialty center for every surgery. So I think it's pretty exciting. We'll see, hopefully get more experience with this and see whether there are some differences in outcomes for patients.
Thank you.
Okay, well, we're going to move on to the next poster. Thank you so much, Dr. Denomme. As I've said to all the other presenters, we hope to see more of your work in the future and hope to see you at future ASRA meetings. This is a great group of people to hopefully make as longtime members. Thank you very much.
Thank you.
Thank you.
Okay, and next up, we are going to have Dr. Nicholas Darensburg. Let me see if I saw him here earlier. There he is. Hey, there he is. Excellent. Let me get your poster up on the screen. Give me 1 second. Got too many screens working here. And let's make it fit. All right, there we go. And so Dr. Darensburg is presenting Erector Spinae block in a pediatric patient with spina bifida undergoing bladder surgery, a medically challenging case. And you're up, Dr. Darensburg.
All right. Good evening. My name is Nick Darensburg. I'm currently one of the acute pain fellows at Virginia Commonwealth University Health Center. I'll be presenting a case report on Erector Spinae plain block and its use for analgesia in a pediatric patient having bladder surgery. So both the adequacy and methods of perioperative pain control have come under increasingly important and sometimes controversial topics in modern anesthesia. Adequate pain control can help promote early mobilization, physical therapy, and enteral food intake. The widespread use of opioids during the perioperative period has come under increased scrutiny, and there is evidence showing a higher rate of persistent opioid usage in the young adult and adolescent populations undergoing abdominal surgery versus other surgery types. So it has become favorable to implement a multimodal anesthetic during surgery. This includes the use of a variety of drugs such as acetaminophen, lidocaine, dexmedetomidine, and ketamine. Also, one may decide to use various anesthetic techniques such as peripheral neuraxial nerve blocks to reduce opioid usage. The ESP nerve block is a paraspinal fascial plane block that was first described in the use of relieving thoracic neuropathic pain. Since then, the block has proven useful for analgesia in a variety of scenarios such as cardiothoracic surgery, traumatic rib injuries, and abdominal surgeries. The objective is to block the dorsal and ventral rami of the spinal nerves. This is achieved by injecting local anesthetic within the fascial plane of the erector spinae muscle and the transverse process, which is pictured on the bottom right of the poster. This result should be a multidermatomal sensory block that can be targeted to a specific spinal level, depending upon the surgery. In this case report, we will present the use of the ESP block as an alternative to neuraxial analgesia in a patient undergoing bladder surgery. The patient was a 6-year-old male weighing 17 kilograms with a history of spina bifida, myelomeningocele, hydrocephalus, and Chiari-2 malformation. Due to his comorbidities, he developed a neuropathic bladder that necessitated bladder augmentation surgery. The acute pain service was consulted to help with post-operative pain control. The surgery consisted of access to the bladder through a midline infraumbilical incision, which is pictured at the bottom of the poster. In this patient, neuraxial anesthesia may have been difficult due to changes in his sacrolumbar anatomy, which may have made the epidural placement difficult or caused an unpredictable anesthetic spread. Therefore, the decision was made to place bilateral ESP catheters. After induction, the patient was placed in the lateral decubitus position, and under ultrasound guidance, the ESP catheters were placed at the T10 to T11 level. 7.5 milliliters of ropivacaine, 0.25%, was injected on each side during placement. The catheters were left at 6 centimeters and 6.5 centimeters on the left and right, respectively. The operative course was uneventful, and the patient was started on ropivacaine 0.1% at a rate of 2 cc's per hour post-operatively. Post-surgery, the patient was seen on a daily basis by the acute pain service. On post-op day 1, the patient reported a pain score of 0. On post-op day 2, the patient reported some discomfort and the rates were increased to 3 cc's per hour. On post-op day 3, the patient and the family reported much better pain control. At that time, it was decided to perform a clamp trial in anticipation of removal of the catheters in the near future. The clamp trial was successful, and the ESP catheters were removed on post-op day 3. At that point, ibuprofen and acetaminophen were able to be used for adequate pain control. And there's a timeline in the bottom left of the poster showing kind of all the medications that were given and the timeline and the rate changes. In this case, we highlight the ESP block and its application in abdominal surgery in a pediatric patient. This case report highlights an instance where the ESP block was used effectively to control postoperative pain after lower abdominal surgery. It proved to be a useful alternative in a case where neuraxial anesthesia may have been difficult or harmful for the patient. In this instance, we were able to control postoperative pain without having to resort to the use of opioids. Like,
Muted again. Okay, excellent, Nick. Thank you. Great presentation. Jan, you want to start? Any questions for Dr. Darensburg here?
Hold on, let me unmute myself.
Yes,
that
theme
works
of the day.
You know, I mean, I think it's, you know, it's a very interesting case because, you know, it's again sort of like, you know, we sort of like sounding like a broken record, but I mean, this is like another analgesic option for a patient that otherwise may have been stuck with, you know, IV or PO pain meds, and it clearly made for a smoother course for this patient.
right.
My question is, like, because with this ESP catheters, I think it may or may not matter what type of catheter you use. What types of catheters did you use? Did you use a traditional system with the catheter through needle or a catheter over needle system? Because from what I hear from my pediatric colleagues here at Stanford, that may or may not make a difference.
So basically, we use an epidural kit. And it would be the standard catheter that comes in the epidural kit. I guess it would be catheter through the needle technique. I know there's different ways of doing it, and that's really the only way I've been exposed to is just going through the needle with the catheter.
Great.
Dr. Nada?
Yeah, thank you, Nick. I think it's an interesting case. And as we see, the ESP is another tool in our toolbox that we can use whenever we can use epidural or like. I just noticed that there was no opioids during the 3 days post-operatively. Was that right, or I missed something?
Yeah, that was right. So that was one of the highlights of the yeah. I guess. So we were able to basically control the patient's pain enough to where he was able to just use acetaminophen and ibuprofen throughout, and some Toradol throughout the post-operative period, without having to use any opioids. So we considered that a good thing.
Thank you.
I'm curious, Nick, how well did this 6-year-old tolerate having 2 catheters in their back? Most of our adults with epidurals are constantly itching their back with tape and squirmy and pulling it and all that kind of stuff. Okay.
It seemed like he tolerated it pretty well. You know, sometimes I round on the APS-2 service, and we'll see the patients with a lot of the catheters. And, you know, just my experience, it haven't really been too much. Maybe it's a different method, be tapers, you know, but I haven't really seen too many people that complain about them being itchy or scratchy too much. So
I wonder if, you know, I mentioned that because I think a lot of times we're nervous about doing regional anesthetic techniques on pediatric patients and, you know, assuming that they're not going to tolerate it. I think it's important to realize they probably do better with it than a lot of our adults do, and we shouldn't discount them. So great job with this presentation, Nick. I think this is, you know, we have a lot of our colleagues who are in pediatric, interested in pediatric regional anesthesia, and I think they're excited to see more of these presented and hopefully published in the literature. So thank you for your presentation, and we hope to see you again at future ASRA meetings.
Thank you.
Thank you.
All right, have a good one.
All right, so let me get our next speaker up, which is Dr. Calixto. There we go. And I'm going to get your poster up here too. All right, Dr. Calixto is presenting perineural adductor canal catheter placement for the prevention of post-operative CRPS-I exacerbation after knee arthroscopy, a case report. You're up, Dr. Calixto.
Thank you. So good evening, I guess afternoon here on the West Coast. My name is Nathan Calixto. I'm a CA1 resident at UC Davis Medical Center in Sacramento, California. So I'll be presenting a case report of adductor catheter placement to treat post-operative CRPS type 1. Arthroscopic knee surgery is a common trigger of chronic regional pain syndrome that is affecting the lower extremities. And there have only been a few studies that have investigated either sciatic or adductor catheter placement to treat lower extremity CRPS. Furthermore, regional anesthesia for the specific indication of CRPS that occurs after knee surgery has not yet been studied to our knowledge. So I'm presenting a case of CRPS type 1 exacerbated by knee surgery on multiple prior occasions, but finally prevented after the placement of a continuous adductor canal catheter. So our patient was a 44-year-old woman who was undergoing right knee arthroscopy, partial meniscectomy, and trochlear chondroplasty. This was actually going to be her 13th surgery on the right knee since 2003. Several prior surgeries were complicated by stigmata of CRPS, such as skin and temperature change, allodynia, joint stiffness, arthritic pain. In addition to that, she was having consistently high opioid requirements, occasionally to the point of withdrawal and dependence. So for the more recent surgeries, she had had trials of single-shot nerve blocks and had between 12 and 18 hours of solid analgesia, but then after that had difficulty requiring opioid medication and had difficulty weaning off of opioids. Her additional past medical history was notable for a prothrombin mutation and then a provoked DVT after left knee surgery in 2018, for which she completed a 3-month course of apixaban. Otherwise, the patient had good exercise tolerance, no cardiovascular or pulmonary issues. She was a competitive triathlete and mountain biker and actually worked as a CRNA at a local institution, not our institution, but in the area. So her literacy about anesthesia was quite high. The intraoperative plan was for general anesthesia with laryngeal mask airway. She did decline spinal. And the plan for regional anesthesia was for pre-op single-shot femoral block. The case was performed in our same-day surgery center, and generally it is difficult to get on-cue infusion pumps there, but we were able to wrangle one, and in addition to, in order to mitigate symptom occurrence when the pre-op block subsided, we decided to place a post-op adductor catheter as well. So for the femoral block, we gave 18 cc's of 0.5% ropivacaine with 1 in 400,000 epinephrine, and the ultrasound image that we obtained is figure 1. And then for the surgery itself, we maintained general anesthesia with sevoflurane, gave Dilaudid, Toradol, and ketamine as adjuncts for multimodal analgesia, and there were no complications. In the recovery room, the patient did report 0 out of 10 pain, regardless, given her history of chronic regional pain syndrome, especially even after arthroscopic surgery. All parties agreed to proceed with the adductor block. 20 cc's of normal saline were injected during placement of the nerve catheter. No additional bolus of local anesthetic was given. The catheter was connected to an infusion pump with 0.2% ropivacaine, and the patient was discharged home with the pump as well as Percocet and Toradol as needed. A little bit of a wrinkle in our plan, due to her history of her DVT, the patient was to start a 10-day course of apixaban prophylaxis, at which point the nerve catheter would need to be removed, and that would have to happen 24 hours post-op. At that time, the patient reported 5 out of 10 pain, took 1 Percocet and 1 Toradol. Her pain level would peak 33 hours post-op at 7 out of 10, for which she required 1 additional Percocet pill, but 72 hours out, the patient actually reported minimal pain or medication requirements, and this continued to be the case at her 10-day post-operative visit with orthopedics. During the entire month after the surgery, she only required a total of 5 Percocet pills and 1 Toradol, and she was able to return to high-intensity physical activity. As far as discussion, post-op single-shot adductor blocks were found to significantly reduce pain scores in patients with moderate to severe pain after arthroscopic knee surgery. And although our patient did not have pain in recovery, her history certainly put her at risk of experiencing severe pain. So we continued with placing the adductor block. Analgesia was likely achieved with decrease in sympathetic tone and vasodilation, which works similarly to sympathetic block and epidurals, but regional nerve blocks provide these effects on a more localized level. While there are only limited studies on continuous catheter placement for CRPS, there are promising results in pediatric population. And although children with CRPS generally show better outcomes than adults, the pathophysiology is more likely than not identical, and so we can apply these results to adults potentially. Existing studies on interventional treatments for CRPS have focused mostly on beer blocks, sympathetic blocks, and neuraxial anesthesia, but Cochrane database reviews have actually shown, at best, moderate to low evidence for these treatments. So there is a void of effective interventional treatments for CRPS, and in particular, CRPS type 1 exacerbated by surgery. And so further study will be necessary to determine whether regional anesthesia and particularly continuous nerve block can help fill that void. So thank you very much to ASRA for the opportunity to present. Thanks to my home institution, as well as Dr. Saldana, who's my co-author and the attending on the case. And I'm happy to take any questions you may have.
Thank you so much, Nathan, for presenting. Ed, you want to start off with some questions?
Sure. I mean, I think it's a very interesting case. I mean, I think the prevention of pain, I think especially in a patient with a history, I think makes, I think it just is a good reminder that each patient's pain experience and story is going to be different. I think it's interesting, I think, because we know the more selective that you get with nerve blockade, the less you cover. And so I was just curious, sure, as far as with the adductor canal block and catheter, if there was a discussion within your team as far as additional coverage, since then presumably the near arthroscopy related pain would not be sufficiently or completely covered by just the domain of the adductor canal block.
Sure. And that is why we did the pre-op femoral block because it is a denser block, has more pain relief, and then it was just for that additional few hours to include the adductor, and also because it spares because it is mostly motor sparing as well, allowing for early mobility.
Dr. Nada?
Yes, so this is a very good case, because whenever you have a chronic pain patient, myself, the most my highest fear is that patient develops uncontrolled pain after the surgery, and the best thing you can do is you prevent it from the start. My question is like Dr. Mariano also, the adductor canal covers a small part of the knee nerve supply, and you also came up with a good plan, started with the femoral, and then did the adductor canal. I have two questions. I wonder if the coverage from the femoral, because the femoral is better coverage and more coverage, so you got the good result because of that. And my other question, did the surgeon inject any local anesthetics inside the knee itself? Because, the knee has different, several nerve supply sources. And the adductor canal covers only a very small part of it.
At this, I'll have to review the intraoperative record, but I can get back to you on that. I don't remember off the top of my head.
Okay.
Well, Nathan, I want to ask you a quick question. Was, one of the conversations that's happening right now is the use of peripheral nerve stimulation as a long-term therapy for these CRPS. Did you guys have any conversation about, the use of local anesthetic in this case for preventing, and maybe downstream sending this person, especially if it's like a test case where the adductor catheter really made a difference, that maybe this is a person that's a candidate for peripheral nerve stimulation therapy as a treatment potentially down the road?
That particular conversation was not had with the patient. This particular case was encouraging, but if we see her again, this is something that we could possibly pitch to her.
Yeah, I think that as we explore these chronic pain patients, we have to remember that we're often given an opportunity to do a trial on them, essentially a functional trial, and it may guide therapy down the road as well. Thank you, Dr. Calixto. I really appreciate you presenting. We look forward to seeing much of your future work at more ASRA meetings, and we're really grateful to have you here. Thank you.
Thank you.
All right, our next presenter is coming up. This is Dr. Stephanie Sutter, And let me get your poster up, Dr. Sutter. Okay, welcome, Dr. Sutter. And Dr. Sutter is going to be presenting on Erector Spinae plain block for pain control in endoscopic percutaneous nephrolithotomy, a case report. And take it away.
Great. Thank you so much for having me. My name is Stephanie Sutter, and I'm an anesthesia resident at UCSF in California. Today, I'll be presenting a case report on the use of the Erector Spinae plain block in endoscopic percutaneous nephrolithotomy. Regarding the procedure, the endoscopic percutaneous nephrolithotomy is a urologic surgery to remove kidney stones. And the procedure itself is known to be quite painful, with significant postoperative pain scores and high opioid requirements. Because of this, it is a procedure that would benefit from an effective regional technique to aid in pain control. As we know, the Erector Spinae plain block is an interfascial plain block that can cover unilateral dorsal and ventral spinal nerve rami at multiple vertebral levels with just a single injection. Although this block has previously described for multiple types of surgeries, its use in percutaneous nephrolithotomies is relatively limited. Here we present a case of a patient who received the ESP block prior to the procedure. The patient was a 71-year-old man with a history of prostate cancer and prior renal stones who presented to the urology clinic with chronic intermittent renal colic episodes. He was found on imaging to have multiple left-sided obstructing stones, the largest of which was 1.8 centimeters in diameter. He underwent a left-sided endoscopic percutaneous nephrolithotomy. The anesthetic management consisted of a preoperative, single-shot, left-sided Erector Spinae plain block at T11, with 30 mLs of ropivacaine, 0.35%, performed in a cephalad to caudad direction with ultrasound guidance, and general anesthesia with an endotracheal tube. The intra-op pain management consisted of a total of 50 mg of fentanyl given prior to induction, and the procedure itself was successful and uncomplicated, and the patient was extubated in the operating room. In the recovery area, he reported just 3 to 4 out of 10 pain located along the left flank that was managed with a total of 1 milligram IV hydromorphone and 5 milligram oral oxycodone. He did not require any additional opioids during his hospital stay. His pain was managed on scheduled acetaminophen and gabapentin until discharge on post-op day 1. So, in conclusion, this case report describes an example of the Erector Spinae plain block to effectively provide analgesia during endoscopic percutaneous nephrolithotomy and throughout the immediate recovery period. When determining what block to use, what block would be appropriate for this procedure, we had to consider where the painful stimuli would be located. There was the somatic innervation of the skin and the muscle during surgical incision, which usually is performed at the 10th or 11th intercostal space. Then there was the visceral pain due to manipulation of the kidney and ureter during the procedure itself. As such, the goal coverage for the regional technique must cover the T10 to L2 levels for effective pain management. And although prior research has looked into the use of multi-level paravertebral blocks and intercostal blocks for this procedure, those blocks can be technically more difficult, associated with more complications, and require multiple injections to cover the appropriate levels. So this case describes the potential of the Erector Spinae block to provide analgesia for percutaneous nephrolithotomies in both the intra and post-op settings. However, further research, including randomized control trials, will be necessary to better understand the efficacy and the benefits of this novel block for this specific procedure. Thank you.
Excellent. Thank you so much. Dr. Bublik, you want to start with this one? I think that, this is another example, as you said, of pushing the envelope.
Sure. This is a very interesting case. So I have several sort of questions. So my question is, how did you come up with a solution of 0.35% of ropivacaine? I've seldomly seen that used outside of France, and who have a penchant for these lower concentrations. And the other thing is, were you considering and that might be our own institutional bias on both campuses, a catheter technique a little bit further away, given that the Erector Spinae block has such a great spread in fascial planes?
Absolutely. So regarding the 0.35% ropivacaine, a lot of our regional attendings did train in Europe, so that may be where some of it came from. But I also think it was kind of finding the balance of a denser block for the procedure, but also being far enough from any sort of dangerous thresholds. In terms of the catheter, I think we do a lot fewer catheters at UCSF than at Stanford. But especially for this patient who ended up being discharged the next day, I think a block ended up being a really good choice.
Okay. Dr. Nada?
I think it's a nice case. And I think the aim was the analgesia rather than the anesthesia, right? The patient received general anesthesia.
That's correct.
Yeah, okay. So did the patient have a catheter placed after or just they did a single shot, like a technique, not our catheter, I mean the PCNL. Did they have a PCNL catheter or tube, I mean?
Oh, actually, I don't know. I would have to look and find that out.
Yeah. Okay.
Yeah, we have a similar problem. A lot of times the nephrostomy tube is the constant ongoing pain source after these patients. I was really struck by this because I work at a center now where we do a lot of urology procedures, and a lot of them are stent and stone procedures done endoscopically, not percutaneously. But ureteral pain is a frequent cause of problems in an outpatient surgery center trying to get these patients comfortable. And so I started thinking, like, it had never really occurred to me to try an Erector Spinae block. Do you think that you get, so the innervation to the ureters are sympathetic often. Do you think, and this is an ongoing debate, so I'm throwing you in the fire here, do you think the Erector Spinae block gets to the sympathetics that provides that analgesia? I mean, did you guys have a conversation about whether it was even useful for that?
No, that's a really good question. And I think a lot more research will have to be done to better understand exactly what's getting covered and how much it's affecting the sympathetic innervation. And we have an ongoing research now. So this was the first time we did this block for this specific type of surgery. And now it's become much more standard. We have an IRB to look, and most of the patients are consenting for it. So I think in the future, we'll have a much better idea of exactly how this block would be helpful in this procedure and a little bit better understanding of what that's actually covered.
Excellent. Thank you so much, Dr. Sutter. This was a great presentation. It got me thinking about a lot of ideas. So like always, we hope to see you at future meetings and all the work that you guys are doing, and especially if you guys are doing a more comprehensive study on this. Thank you again for joining us.
Thank you so much.
All right. Let me get our next speaker up here. This is Dr. Ryan. Is it Ferenc? Ferenc. Dr. Ryan Ferenc is joining us. And let me get your poster up here, Ryan. And he will be presenting on ultrasound-guided neuraxial and regional anesthesia for a parturient with patellar fracture and complex neurologic history. And you're up.
All right. Good evening. My name is Ryan Ferenc. I'm a resident at Weill Cornell in New York City. So I'll start off with the case. The patient was a 34-year-old pregnant female who was 37 weeks gestational age, who presented for outpatient surgical repair of a fractured right patella that she sustained after a fall. She also was newly diagnosed with multiple sclerosis during her first trimester after presenting with an episode of ataxia and vision loss. She also has a history of a conus astrocytoma that was resected 2 times during her childhood through an L2 thoracic to L2 laminectomy. And she was known to have matted nerve roots in her cauda equina, and she had chronic sensory motor deficits in her left L2 to L5 distribution. During a prior pregnancy and labor epidural, she reported inadequate lumbar and thoracic analgesia. And after reviewing the labor anesthetic records, it revealed that the epidural was placed using surface anatomy guide solely. So this case presented several challenges to the treating team. Firstly, due to the patient's pregnant status, she expressed a strong desire to avoid general anesthesia. She was known to have abnormal neuraxial anatomy, and the failure of the previous labor epidural suggests that she may have had some epidural scarring, or it was possible that using the surface anatomy alone, there was possible inaccurate identification of the lumbar inner space. The patient also had this history of lumbar plexopathy in her contralateral lower extremity, and the new onset MS diagnosis also complicated the anesthetic strategy for this patient. So following a discussion of the risks and benefits of general versus regional anesthesia, the patient opted for a peripheral nerve block for her postoperative analgesia and a lumbar epidural block for the surgical anesthesia. Preoperatively, the patient received a mid-thigh adductor canal block, which was performed under ultrasound guidance, and this was specifically chosen over a femoral block for its reduced motor effects given the patient's history of contralateral lower extremity neurologic deficits. For surgical anesthesia, the patient received a lumbar epidural. The surface anatomy was marked using ultrasound guidance. Subsequently, the epidural space was accessed and a 19-gauge epidural catheter was threaded into the space. Following administration of the anesthetic agent, the patient achieved satisfactory motor and sensory block of the right lower extremity. The patient tolerated the procedure well and also tolerated the thigh tourniquet, which was inflated for a total of 90 minutes. At the conclusion of the case, the epidural catheter was removed and the patient was transferred to PACU. About 1 hour post-operatively, the patient experienced an acute increase in pain from 0 out of 10 to 8 out of 10 in the mid to distal thigh. The treating team performed a sensory exam at the time of the lower saphenous distribution and did find that the patient was numb to pinprick. However, a rescue femoral block was offered to the patient and she accepted it. The femoral block was also placed under ultrasound guidance, and following administration of the block, the patient reported marked improvement in her pain score from 8 out of 10 back to 1 out of 10. So discussion of this case brings up three interesting points. The first, when considering the anesthetic plan for a patient with abnormal neuraxial anatomy, the treating team had to make a decision between pursuing epidural versus spinal anesthesia. Spinal anesthesia was initially considered as an alternative to overcome the patient's laminectomy-related anatomical challenges and also to address the high risk of a failed or asymmetric epidural block. However, ultimately, the treating team decided against spinal anesthesia due to the known presence of the matted nerve roots and the concern that introducing a needle could cause direct needle trauma to the nerves or possible intraneural injection. In addition, the ASRA 2015 Executive Summary recommends that epidural anesthesia is safer than spinal anesthesia in patients with MS due to the concern of causing direct toxicity from intrathecal injection of the anesthetic agent. The second point highlights the utility of neuraxial ultrasound, especially in patients with altered neuraxial anatomy. The patient had two encounters with epidural anesthesia, and during the first encounter, she had inadequate analgesia following an epidural that was placed using solely surface-guided anatomy. The second epidural was much more successful. There have been several random controlled trials and systematic reviews that have also confirmed that neuraxial ultrasound is much more accurate in identifying the lumbar intervertebral levels compared to surface anatomy alone, and that using neuraxial ultrasound can help lead to significantly lower rates of incomplete analgesia. Finally, there's some controversy surrounding peripheral nerve blocks in patients with multiple sclerosis. It's known that post-operative and surgical stress and pain are risk factors for MS relapse, and also that MS is not confined solely to the CNS. There's a 5 to 47% of patients with MS may additionally have subclinical peripheral neuropathies. And there have been several case reports that have described iatrogenic peripheral neuropathy following administration of a peripheral nerve block in MS patients who likely also have pre-existing subclinical neuropathy. So the decision to pursue a peripheral nerve block in the patient might have been a little controversial, but it was a balance of the benefits of NSAID and opioid sparing analgesia in this 3rd trimester pregnant patient against the risk of iatrogenic peripheral neuropathy from the nerve block. Thank you.
Excellent, Dr. Ferentz. Thank you so much for your presentation. Ed, you want to kick off the conversation here? And you got Dr. Ferentz, you have a nice applause from Dr. Terrace Gross, who's applauding your ultrasound use for neuroaxial. So I want to give him credit for his shout out there.
Yeah, this is, I mean, it doesn't get too much more complex than this, I mean, in terms of decision making. And I think that this is a great example of how, sometimes real life is often more difficult than a board question. So I think there's no right answer. So I think weighing all of the different risks and benefits of different techniques. I mean, I think clearly the combination that you all decided on was really a great personalized approach for this patient. So I think, lots of kudos to you, I think, for just a fantastic demonstration of how anesthesiologists practice personalized medicine. But yeah, I mean, I think that this is definitely something that we'll never really have a straight answer on whether regional anesthesia is safe for this patient population, because we'll never have RCTs. But I think it is good to have these kinds of cases to learn from. So great job on taking care of the patient.
Thank you.
Dr. Nada?
Yes, this is a very interesting case. I loved it a lot. So it has multiple challenges, as Dr. Mariano said, and this is shows you think now as a physician, you're not just doing a block, you're putting all the pieces together. So I'm going to go quickly over, there's a couple of things we can take home from this case. So there's multiple things actually, but I want to focus on. First, congratulations for your ultrasound picture. So nice of the spine.
Thank you.
Must have a very good ultrasound machine. Okay.
Yeah.
The other thing is even the literature is very confusing about the neurological regional anesthesia in the presence of neurological disease like MS. You mentioned the point of spinal, epidural, and it's still controversial. But you had also some other factors that prevented you from doing the spinal. The other thing also, they tell you don't use too much local anesthetic, don't use high concentration, but they don't tell you what is the proper concentration, right?
Yeah.
So it happened to me, I had a cesarean section with something like this, and I wanted to do I did it with epidural, and I said I'm gonna go with bupivacaine 0.25. I'm gonna see if that's gonna work or not, and actually the patient did really well. Never felt anything. 0.25. The other point also, the fracture of the patella, I had some disappointing results with Adductor Canal. So, and those patients don't go home, don't walk on the first day. They usually go on immobilizer. So go ahead and do femoral nerve block. Patella, although it's a small bone in front of the knee, it has a complex innervation. And it's not totally femoral, but the femoral, most of it. These are my 2 points.
Given we initially chose the adductor canal block just because she had this history of neurologic deficits in her other leg, so we wanted to try and avoid, a possible motor block if possible. But obviously, it didn't provide complete analgesia for the patient. We had to do the femoral block as well, anyways.
Yeah, Ryan, I had written down several notes of why didn't you do this or why didn't you do that? And then I realized I'm sitting there armchair quarterbacking something that I wasn't there. And actually, you guys did a great job. So these are one of those cases it's easy to armchair quarterback from a distance and after the fact. But when you're looking at that patient straight in the face and you're trying to come up with the best solution, often the best solution is trying, try, as Dr. Nada said, you got to try something and not just kind of go, throwing up our hands, let's just do general anesthesia and give them a bunch of opioids, because that's also not good for their neurologic disorder. Well, Dr. Ferentz, thank you so much for your presentation. We really appreciate you having the time to come out today, and we hope to see you at future ASRA meetings.
Thank you so much.
Thank you. All right, and we have one last presenter today, and that's Dr. Chris Hull. And let me get his poster up here. Hang on one second. All right, Dr. Hull, welcome. And he's going to be presenting on intrathecal dexmedetomidine and fentanyl for postoperative pain management in a patient on naltrexone maintenance therapy. Talk about another series of difficult blocks to navigate. So, Dr. Hull, go for it.
Yes, exactly. Thank you. Yeah, my name is Chris Hall. I'm one of the acute pain and regional fellows at the University of Pittsburgh. And a little bit about the background before I kind of get into the case presentation. As we're all aware, doing anesthesia, opioid abuse is a national kind of as well as global crisis going on. And a few of the statistics that I found while looking up this case presentation and working on it that I thought really kind of put it into perspective was one from a national survey in 2018 kind of showed that there was an estimated 10.3 million people who were age 12 or older who had misused opioids in the previous year. And then another one from the U.S. Department of Health and Human Services showed that between the years of 2016 and 2018, there was a 142% increase in patients who are now on medication-assisted treatment for opioid abuse. So, given these numbers of people who are on medications as well as abusing opioids, anesthesiologists, can encounter the patients in many different situations, whether they're, acutely intoxicated coming to the OR, chronically abusing narcotics, or they are on maintenance therapy ranging either from methadone for opioid de-addiction to, maintenance therapy as our patient had naltrexone injections. Patients who are receiving naltrexone injections present unique challenges to the anesthesia providers because they have an altered response, obviously, to the effect of opioid agonists. So yeah, here in our case, we had a patient here who was on monthly naltrexone and trying to figure out, what we could do to help her with postoperative analgesia. So our patient was a 40 to 45-year-old ASA3 female with a past medical history of hypertension, schizophrenia, polysubstance abuse, which included cocaine, marijuana, heroin, hydrocodone, oxycodone, codeine, and amphetamine abuse, who was, like I said, on monthly naltrexone injections, and also with T1C N0M0 invasive lobular carcinoma of her right breast. And she was presenting for surgery for right breast reconstruction and a right lateral intercostal artery perforator flap. She had told us she had denied any illicit drug use in the last 4 years. Her last use was 4 years ago when she had a seizure from cocaine use, so she obviously was trying to stay away from any narcotics as well as any other illicit drugs. Prior to the surgery, the patient, what we did for her was a right T3 ultrasound-guided paravertebral block, which is the first figure I have, as well as a right T5 ultrasound-guided paravertebral block, both using 0.5% bupivacaine and 2 milligrams of dexamethasone. And then we also performed an intrathecal injection of 30 micrograms of fentanyl as well as 12 micrograms of dexmedetomidine. After the procedure, the patient was then induced for general anesthesia. She was not given any narcotics intraoperatively or in the PACU afterwards after she was, transferred from the OR. Postoperatively, we started her on a multimodal pain regimen, which consisted of Tylenol every 8 hours, 200 milligrams of Celebrex daily, 300 milligrams of gabapentin at night, as well as a lidocaine patch topically. We also did order her 10 milligrams of oxycodone as needed for any breakthrough pain that obviously wasn't covered by everything else that we had done. So following up on her on post-op day 1, she actually received a total of 3 doses of the 10 milligrams of oxycodone at 13, 19, and 28 hours post-extubation. And then post-op day 2, she received 2 doses of oxycodone at 37 and 42 hours post-extubation. She didn't get any other opioid medications during her hospital stay, and she really didn't report that she needed any more than those. On both post-operative days that, I went and saw her, she reported her pain being controlled on the current medication regimen, which ranged anywhere from mild to moderate. She said the highest it got to was, a 5 or a 6, which is when she would take the oxycodone. And then she was discharged day 2 home in very good condition. So kind of getting into the discussion part of this case, as I previously mentioned, patients receiving extended release naltrexone who are having surgery present unique challenges, the most obvious of which is, an altered response to the effects of opioid agonists. As we all know, naltrexone is an opioid antagonist, so it binds to the receptor and prevents agonists such as heroin or prescribed opioids from activating the receptor. Patients who are on naltrexone therapy are usually patients who have a history of opioid abuse. And these patients presenting for surgery are likely to have postoperative pain, obviously. And in this subset of patients, commonly used opioid medications are likely not to work at their usual dosages. Also, depending on the timing of their last dose of the naltrexone, patients may be more sensitive to the harmful side effects of the opioid medications due to receptor upregulation secondary to antagonism. So, we kind of wanted to find a multimodal approach for her, which included obviously all the other medications that I talked about, NSAIDs, acetaminophen, alpha-2 agonists, gabapentinoids, as well as, regional techniques. So in our patient, as I mentioned, we did the 2 paravertebral blocks, T3 and T5. And then we also did the intrathecal procedure with fentanyl and dexmedetomidine. And our thought was to help prolong the quality and length of the paravertebral blocks that we placed preoperatively. Dexmedetomidine, as we all know, acts on is an alpha agonist that acts on both alpha-1 and alpha-2 receptors. So the binding ratio for alpha-1 to alpha-2 is 1 to 1600, which makes it highly selective for alpha-2, which when compared to clonidine, which is kind of what we were thinking when we wanted to use it to help decrease the unwanted side effects of clonidine, specifically hypotension. Some studies that I have in my references have shown that when dexmedetomidine is added to local anesthetic, it can prolong the length and quality of peripheral nerve blocks. So one study in particular showed that when given intrathecally with local anesthetics, the onset of sensory block in the dexmedetomidine group compared to the control group in fentanyl was significantly lower. The duration of the sensory block was significantly longer, and the duration of the motor block in the dexmedetomidine group was also significantly longer. Another study showed those exact same results, but they kind of went a little further as well. And they looked at, the dexmedetomidine group had prolonged postoperative analgesia, as well as reduced total doses of analgesics needed to be used, which obviously in our case was one of the goals we were going for. Another adjuvant that, has been used to prolong duration and quality of peripheral neuraxial blocks is intrathecal morphine. However, one downfall to the use of intrathecal morphine is the need to monitor these patients for 12 to 24 hours for delayed respiratory depression, as well as other side effects of, prolonged opioids. So that's obviously not ideal in some subset of patients, patients who are morbidly obese, patients who are highly sensitive to opioids, or those, presenting for same-day surgery who are looking to go home. However, the use of Precedex and fentanyl does not cause delayed respiratory depression and can be a good adjuvant in these sort of cases. So to kind of wrap up my case discussion here, providing surgical and postoperative analgesia for a patient receiving, extended release naltrexone can be challenging. And using regional and local anesthetic techniques as well as non-opioid adjuvants is obviously a good approach to these patients. And here we kind of just talked about, considering using intrathecal dexmedetomidine and fentanyl as a way to increase the quality and duration of your peripheral nerve block. And then that is all I have for this. So
Thank you, Dr. Hall. Excellent presentation. I'll start off with a quick question. This conversation reminds me of a lot of the conversations around buprenorphine patients as well, who are on maintenance therapy and often have issues with withdrawal and opioid agonism when you come in for acute pain related surgical procedures. Was there a conversation with this patient, or was there time to talk about considering weaning? Is naltrexone something that should be weaned? We went back and forth on the value of weaning buprenorphine and have sort of settled on leaving it alone and sort of using all the multimodals like you described on top of that.
Right. We talked with the patient. Now, obviously, since she was getting an injection, the recommendation for naltrexone oral tablets, hold for 2 to 3 days beforehand. But since she's getting monthly injections, the thought that she had talked about, with the surgeon previously was they had scheduled her surgery, 4 weeks from her last injection, and she was supposed to get her next injection the next week. With the thinking being that, that's coming down from her last dose, maybe give her the most ideal time to kind of hopefully overcome some of that antagonism should she need it post-operatively. So us talking to the patient, we mentioned to her that, she may be having, it's going to be harder to control pain than maybe a normal patient would, which is why we want to try these different approaches that we mentioned to her. But, that given her naltrexone injection, this is just something that, we would have to try.
I think there's some really great lessons there just about, I mean, just in your response, I mean, about communicating with patients and their primary prescribers for a lot of these medications, just so that, because so much of this is timing, right? I mean, if it would be one thing if, you know, she came in as a trauma and you weren't able to time her surgery based on her prior dose of her naltrexone. But I think this coordination, I think, is probably, and that's what sets you apart, I think, as a specialist physician, rather than being focused too much on the technical aspects. But I thought this was a great care of the patient. We're seeing more and more of these antagonist drugs or mixed drugs, I think, in clinical practice. I mean, I think our first real experience trying to manage naltrexone, I think you'd mentioned the oral formulation was really patients being prescribed naltrexone for weight loss in preparation for their bariatric surgeries. It just wasn't something that we had really thought about until it shows up on their med list.
Right.
So I think that we have to be aware of these things. I'm not familiar personally. I haven't given intrathecal dexmedetomidine. So yeah, I know I'm familiar with clonidine and its use, preservative-free clonidine for epidural and spinal use, but not in part of my practice as of yet.
Right. And this was obviously my first time doing that as well. And the way we did it was my attending who was on the acute pain service that day is also one of the OB attendings. And he said he had tried it out with some of the OB epidurals before in patients that he was a little reluctant to give clonidine to. Again, you know, maybe their pressures were a little borderline and he didn't want to cause that more, but they needed a little bit extra through their epidural. So he said he had tried Precedex before and, you know, had some good results with it, which is what gave him the idea to try this, which is why we thought it was an interesting case.
Thank you.
Well, Dr. Hall, thank you so much for your presentation. Again, another innovative case scenario that hopefully none of us have to deal with too often, but as Dr. Mariano suggested, you know, unfortunately, we may have more and more of these patients come across our way. So it's important to have these tools in our back pocket. Thank you for your presentation. We hope to see you again at future ASRA meetings and more of your research and hard work. And we really enjoyed having your presentation. Thank you, Dr. Hall.
Thank you, everybody.
So as we wrap up here, I want to thank our co-faculty. We managed to get through quite a few abstracts today, and just under the wire, we were supposed to finish at 8 p.m. Eastern time, and we're 3 minutes short, so that's pretty good considering the number of people we went through. So I congratulate our presenters for staying on time as well. I want to remind everybody the ASRA meeting starts this Thursday. Join us on social media, hashtag ASRAspring21. If you're there or if you're not there, there's going to be a lot of conversation on Twitter and Facebook over those connected to those hashtags. And then if you haven't registered for the virtual meeting and are not able to attend in person, I encourage you to do so. You can still do that. And I think you're going to get a lot of great content. We're all craving new information regarding regional anesthesia because we love it so much. So it's important to see what's out there and what new things that people are doing. Thank you, Dr. Mariano, Dr. Nada, Dr. Bublik. I really appreciate having you guys here, and look forward to seeing all you guys in person soon.
Thank you.
Great job, Raj. Thanks for moderating.
Bye.
Take care.
Have a good night, everybody.
Bye-bye.